Let's start now. Okay. Good morning, good afternoon, and good evening, everyone. I'd like to welcome you to the third session of the Jazeera Rural Primary Care Echo Program, held today on the 22nd of October, with our very prolific program director, Professor Majd Hadi. Right. Before we start, as usual, we have a few housekeeping reminders. Discussion makes these sessions work best, so please feel free to share your ideas, thoughts, and questions with us in the chat or whenever you feel like it. And if you can, please raise your hands and unmute your microphone so you can ask your questions or give us your beautiful insight. We also love to see your faces, so if your internet connection allows and if your bandwidth allows it, please open your cameras so we can have a more interactive session. Please stay muted unless you are speaking. We understand that sometimes microphones get opened by mistake, so it's okay. Please just remember to check it and stay muted if you aren't speaking during the session. Lastly, the sessions are recorded and we will send a link out inside the recap email that we send after each session. Also, you will be able to find the session's presentation on the iEcho platform for you to download and view as you wish. The general outlines of our session for today, or the skeleton of our session, as I like to call it, or backbone, as you can see, as we started with the general, with the welcoming and introductions, then the session reminders that we've just gone through. We're going to have our didactic session today with Mr. Jeffrey Wetherhold, talking about applying quality improvement to vaccine hesitancy. Then we're going to be going through our case-based discussion presented by Dr. Muhammad Abdul Hamid. And finally, we're going to be having our general Q&A as usual. Before we start, I'd also like to thank the participants for today, the University of Nebraska Medical Center for their continuous support and help. Same goes for the Global Echo team and the Echo India team, the University of Jazeera Faculty of Medicine Faculty of Medicine faculty, and the University of Jazeera Faculty of Medicine students, and every other guest that we have. Before we start, I'm just going to go a very quick demonstration on how to register for the iEcho platform. Just give me a second. I'm going to share my screen again, showing how to register and how to get the session reminders and certificates for our sessions. All right. So when you do open the link that we sent out or you scan our QR code, that you're going to get this page if you haven't already registered. So what you do is you continue with email, because do not choose the continue with mobile phone option because the platform is not working with phones yet. So here we click continue with email, and then we add in an email that we would like to register with. And if we do not have an account already, it tells us to create one. As I said, we enter our data. And then choose any password that we wish and confirm it. After you send in your data and your email, you're going to get this message prompting you to enter a code. This code will be available on your email, so you should check the email that you registered with. And here it is, 158341. And then you agree and continue. Then it asks you to enter your profession. So say you are a student at the University of Jazeera. Here. And then you can continue. So it then prompts you to choose your time zone so that it can choose the time zone and show you the session dates and timings according to your own time zone. And then you're going to have to go back to the link that we usually send, I believe. Give me 1 second. I'm going to open it from my presentation. Yes. Okay. So here it tells you that you can register. And once you have registered, you're going to see the schedule of all the sessions that we have. Whenever the session starts on a day, you can come here and join the session. You're also going to find the case presentation for each session and the PowerPoint presentation that we're using here for you to view or download. This platform will also give you the ability to record your attendance by logging in so that it makes it easier for us to send you the certificates. And finally, you will be able to find your certificates here at the platform. As you can see, I do not have any. All right, and so now we can go back to our presentation. All right, as I said, you can find this link and the QR code on the website themselves, so you can download them if you wish to later. And now we're going to be moving on to our didactic presentation with Mr. Jeffrey Wetherhold of Ohio Advisors. Mr. Jeffrey, are you there?
I am. Thank you so much for having me.
It is our pleasure. Please take it away.
All right. Thank you, Mustafa, and thank you everyone for being here. I really appreciate the opportunity to join the session and to learn from your work and really to have the chance to contribute to all of the good work that you're doing in your community. So as Mustafa said, my name is Jeff Wetherhold. I'm a process improvement expert. I work with organizations to help them build their capacity to create sustainable change and client-centered change. We can move to the next slide, please. And in my work, change is a process. My work draws on several different skills at various points in that process. Sometimes it's curriculum and materials development at the outset. Sometimes it's training and coaching, a lot of the time, to help navigate the change process, change management with leadership and with frontline staff, and then measurement and evaluation to understand what we've learned through that. I've worked with inpatient facilities, outpatient clinics, community health centers, long-term care and elderly facilities, educational systems, businesses, governments, and nonprofits. I really like working with different kinds of organizations because I get to learn different things from all of them, and I get to bring those things back to sessions like this. So again, I really appreciate the opportunity to be part of this program and to get to see some familiar faces and some new faces on the session today. Next slide, please. So our goals, or my goals for my portion of the session today, are to make sure that we have a shared understanding of what quality improvement is, and we'll use the abbreviation QI, what kinds of problems it can help us address in healthcare settings. I want to make sure that we have an awareness of how some basic QI tools can help us establish a focused problem statement using the example of COVID-19 vaccine hesitancy, which I know is an example that is likely very relevant to many of you in your work. And then talk about some best practices and techniques that I've seen other organizations with the same use, and how we can apply those techniques in an improvement mindset to improve the interactions that you have with community members around vaccine hesitancy. So thank you very much for moving to the next slide already. So QI is a discipline and a set of tools that can help you build your capability to design and maintain reliable processes and change over time. When I present sessions to new groups, I typically encounter two maybe objections, points of hesitation, right? Things that give participants pause. And one is, many times people tell me, well, they've seen this before. Typically within a large group, familiarity with QI differs, and that's okay. So I want to acknowledge that some of this may be familiar to you, but we always learn something from revisiting fundamentals when they're the right fundamentals, and having another chance to apply those. And I want to acknowledge that for some of you, QI may be new. And in that case, I hope that this is a helpful starting point, and I'm happy to stay in touch if you have follow-up questions about any of the content that's shared today. The second thing that I often hear is that this seems simple. Sometimes I'll even hear this seems too simple. This feels deceptively simple. QI always sounds like what we want to do, or what we think we should be doing. But even if you're doing it, it takes taking simple work and keeping it simple over time is really hard. Making that simple work repeatable is even harder. Doing that in the middle of a crisis, like a worldwide pandemic, is harder still. So please don't let the simplicity of some of what I'll share today fool you. It's a very simple thing to hear. Sometimes it can be really hard to translate it to daily work. And one of the things I like about this is how humbling that is. Reliable implementation is rarely simple. And that's really where a lot of my work lives. So QI is not an appropriate approach for every problem that you're going to solve. And good quality improvement always starts with questions. So I thought we'd start today and walk through 3 fundamental questions that can help you understand something about where QI can be helpful to you and where perhaps it can't be. So next slide, please. Yep, thank you. So the first question I want us to think about is your problem systemic or is it individual? Now, if folks have access to the chat, I would love to hear your thoughts. What do you hear when I say that something is a systemic problem? What does that mean to you? Or if you don't know what that means and you're feeling brave enough, you can say that too. I wish I heard that a little more than I actually do. I see we have a hand raised. Is it Dina?
Yeah, hello.
Hello.
So I think what is mean is systemic. That means there is lots of parts that integrated in it that make it so intricate and more problematic and more serious. So you cannot solving it by just taking it as it is. You need to break down and take every simple part of it and deal with it. Then you find yourself with a simple node or a simple problem that you can easily solve.
You can be my co-presenter for my next session. That's a fantastic answer. I really appreciate you sharing that. So lots of parts. You can't solve it by just addressing one of them. That's fantastic. I see a couple of contributions in the chat. A problem that runs through all levels of an organization, right? That's not confined to one level. A problem that's a group problem. That's a great short definition of what this is too. We can move on to the next slide. Talk a little bit more about what we mean by systemic. So this gentleman is W. Edwards Deming. He's often thought of as being the father of quality improvement. He lived not very far from the University of Nebraska here in the United States, and he did not start this in healthcare. Quality improvement started as a discipline in agriculture and manufacturing to help with change management. And the key to a lot of what Deming discovered is that most problems with quality are system problems. Right? In his estimation, 94% of the opportunities for improvement are system problems, and the remaining 6% are individual. So the good news is that QI is helpful for system problems, and the vast majority of the problems that you're likely to encounter are going to be systemic. He also believes system problems aren't the responsibility of the frontline staff to fix, right? These are the responsibility of management. Frontline staff cannot fix system problems on their own. And he believed that it's easy to overlook them, right? We often hear things like, well, this just happens all the time. Or that's just how it's always worked. Or it's just the way we do things here. Those are clear signs to me that there's likely a system problem to speak to. And when people articulate a problem that way, when they state it that way, it makes it impossible to fix. We aren't as good at framing system problems as we are at individual problems. And that's part of what QI, I think, can be helpful with, is recognizing and framing problems that naturally we struggle to frame because they're so much bigger than one individual. Next slide, please. Next question we want to think about is your aim research or improvement? Anybody want to venture a guess? Why does this matter? Who cares? It's something related to systems, the process and the activities flow, right? That's a bit different from a research question. Thank you, Alon. Anybody else? Why does this matter?
I believe it matters because the quality improvement project that we are planning for something would then have to be shifted, because if we're only researching, we don't really need to plan out the whole project and how to improve the different levels or the different problems in the system. But if we're aiming towards improvement, then along with looking into the problems, we also need to think about how they can be fixed and improved.
Yeah, you don't have to plan all the way through. That's a great point. I see a couple folks agreeing. I see a comment from the University Hub that they have an answer there in the hall. Is there somebody who'd like to speak up?
Well, I think the first step of improvement is identifying the problem, and research helps us identify this problem. So it can be a part of the process of solving a problem or
I'm sorry, it broke up a little bit as I was hearing that, but I did hear that, improvement starts with a good problem statement, and research maybe attempts to define that problem statement. I apologize if I didn't catch all of that. Zoom is an imperfect medium for communication. I think we've all grown to accept that over time. We can move on to the next slide, please. So I want to talk a little bit about what the difference is, in part because I often hear this used dismissively. Oh, that's not a quality improvement problem, it's a research problem. I can't help you. And that attitude is one that I struggle with personally, because I try to err on the side of helping people. Research seeks to generate new data in order to understand what actions are in a patient's interest, right? As researchers, what we're trying to do is to learn about what a best practice is. So research focuses often on questions of outcomes. What are the outcomes that we should be seeking, and for who and when? And I know there's a lot of detail underneath of that. QI relies on existing data. If we don't have the data, that's a sure sign for me that it is not an improvement problem. It relies on those data to make actions that we already know are in patients' interest more reliable. If I'm trying to reduce wait times in a clinic, nobody believes that a longer wait time is in the best interest of the patients in that clinic. We've established that. Now let's understand how we can implement it. So as QI professionals, we're trying to translate best practices into reality, because reality is much harder than the theoretical. We're focusing on questions of implementation. How can we achieve outcomes that we know are important to us and to our patients? So why is that important, right? Doing QI when you need research is a recipe for going in circles. You're not going to know what your outcome is. You're going to have the same meeting every quarter or every year. Doing research when you need QI is a recipe for not getting useful results. You may have some strategies for implementation, but you're not clear on what it's most important to be implemented. Next slide, please. Our last question that we can think about is, are your activities design or improvement? I want to stress these are not the same thing. Part of what makes it tricky is that the same tools that we use in QI can be really helpful for design and improvement. They can also be really helpful for research in a lot of cases, to the previous question. I would encourage you to use these tools for any purpose where you can find use, but to be very clear about what your intention is when you do so that you use them wisely and get the most value out of them. When we treat an improvement problem as a design exercise, what happens is we act as if the process doesn't already exist. And there are people out there who are making that process run. So we're alienating them. We're turning them off. QI is dependent on frontline engagement. We're probably leaving a lot of knowledge underutilized or unused entirely if we ignore that. And we're ignoring the fact that we're sitting back to design a system that's already happening. The people who are making that system work cannot change everything that they're doing on a dime, right? We're ignoring the human element of how hard it is to make change in your day-to-day work while you're still doing the work. We don't have the luxury in QI of taking a system offline, of stopping everything that we're doing and designing from scratch and then starting fresh. We're trying to improve a system without taking it offline. And that's a big part of what I hope the value is that QI can add. Next slide, please. So quick recap, what kinds of things, when can QI help us? What kinds of issues can it help us with? When our problems are systemic, not individual. Good news and bad news, that's most of the time. They're harder problems. When the aim is improvement and not research, and I want to note that means that you know something or think you know something about the solution. And one of the things that makes the early stages of the QI project hard is keeping the solution or a potential solution out of your problem statement. And yet in improvement, by definition, you're going to have some assumptions or some hypotheses about what those solutions could be. If we recognize them as assumptions and hypotheses, that's okay. If we don't, and they seep into our problem statement, which we'll talk a little bit more about later on in the session, that can become a problem. And we want to look for when activities are seeking to improve an existing system. not to design a new one. Again, QI tools can be really helpful in design. If they're helpful to you, these are tools. Use them for whatever purpose where they can do good, but recognize that's a different activity and they may need to be used in different ways or in a different sequence than they might be in improvement work. Next slide. So how does QI help us? It helps us by structuring change to ensure that we can leave the system online, that we can make change while the system is active. It helps us support continuous change through small improvements over time. It takes big problems and breaks them down into small changes that we can make, which can be hard to identify sometimes. It incorporates existing data into our decision-making, right? We build on the data we already have, and it engages frontline staff. It draws on the wisdom of the people who are actually doing the work on a day-to-day basis. So in that vein, QI work doesn't always offer solutions right away. It offers tools that can allow you to surface your own solutions, whether it's learning from other facilities or other individuals in your own organization. And that starts with a foundation of listening and prompting, which then gets transitioned to more structured work. So we'll talk a little bit more about that today. I hope that's helpful in thinking about what QI is and where it can be most helpful to us and where it can't, because I often hear a lot of confusion about what the difference is between research and quality assurance and quality improvement. And if we don't start from a shared understanding of what the limitations are on quality improvement as a skill set, it's difficult for me to understand how we can use it well. Next slide, please. So this is the model for improvement. And there are several frameworks out there on how to approach QI. This is the one that I have been trained in. This was co-developed by the Institute for Healthcare Improvement, which is an organization that I used to work for and I'm now a faculty member with, and Associates for Process Improvement. Other models out there are also very good. Lean, Six Sigma. The model that is best is the model that speaks to you, that works to you. This is a model that speaks to me, so it's what I teach. All of them rely on successive and rapid cycles of change that build on one another. In this case, through a Plan, Do, Study, Act framework, or a PDSA cycle, as we call it. QI is basically a set of tricks to help you learn faster than you think you can through breaking change down into small changes. And my favorite part of this model is actually just the 3 questions at the top, because I think there's a lot of value in these and they're deceptively simple when we look at them. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in an improvement? It's very easy to feel like we've answered those questions even when we haven't. And the results of not answering them might sound familiar to some of you. So what happens when we don't know what we're trying to accomplish? We don't know what our goal is. We chase things that may not even be there. We waste a lot of time and we don't understand what the bounds on that conversation ought to be. What happens when we don't know if a change is an improvement? Often we don't choose the right changes. If we do, we don't understand when to stop testing them. We cycle through the same change over and over. We try to refine something without definition on how to refine it. We end up wasting our time and getting disillusioned with the change process and probably losing goodwill from people who we need to be our allies in the change process. And what happens when we don't know what changes we can make? Well, we search for ideas. A good brainstorming session or idea session is fantastic. One without bounds can be really hard, for me at least. And some structure on that in terms of what changes we're trying to make is helpful. Otherwise, every idea that every individual may have comes into our solution set, and it's almost impossible to narrow those down once you've received them. If we start with bounds, if we start with some notion for what kinds of ideas will be most helpful, or some metrics to help us know what ideas are most helpful to us, that creates a solution set that's much easier for us to manage. So when we're thinking about what we're trying to accomplish, this is an aim statement, which we're not going to go in depth on today. What's the problem or the opportunity? How much are you going to achieve by when and for whom and where? Think about how we know that a change is an improvement. There are a lot of issues under this around reliability. Is a change necessary? If there's an existing process, where is it reliable? Where is it unreliable? What can we do about an unreliable process? There's a lot of questions smuggled in under that question number 2 there. And then for the third question, what kinds of changes can we make that will result in improvement, right? What ideas can we test and implement? The key to doing that well is finding the parts of a process that are unreliable and whittling that down to changes that are small enough for us to make quickly. And that skill is so fundamental that I pretty much teach it every day of my life. Next slide, please. A little bit more about reliability. So we refer to QI sometimes as reliable design or reliable process design. And I want to acknowledge that reliability does not mean perfection. And that's okay most of the time. So quality improvement emphasizes high performance rather than perfection. We're going for very good, not perfect. It doesn't require that you design contingencies for every possible thing that can go wrong. It wouldn't be realistic within a quick time frame. It takes processes that can be complex or hard to implement and simplifies them for us. It engages small groups rather than large teams. And as I said earlier, it depends heavily on frontline input. So in order to make reliability an asset, we need to understand what processes are frequently unreliable and how. Except that if we're trying to create perfect processes, that's going to keep us from creating reliable processes. And to build a toolkit, which I hope that QI can help with, that is simple and approachable and requires few resources and that you can use quickly. Next slide, please. So one of the big reasons to focus on reliability and not perfection in a problem is that in improvement work, we are managing adoption, change adoption. How quickly do people accept a change? And adoption is never perfect. So this is Everett Rogers' diffusion of innovation curve. This was originally published 60 years ago, actually, at this point. It was part of his theory of the diffusion of innovation from a book by the same name, The Diffusion of Innovations. He argued that diffusion is a process by which any change is communicated over time among the participants in a social system. And that the ways in which they accept, or the speed at which they accept those changes, is variable, but that it varies in a pretty predictable way. Adoption tends to look something like this for pretty much any change that we put out there. So it shouldn't be surprising that adoption for vaccination has looked something like this as well. And yes, it could be a bit differently distributed from place to place, from population to population, but it's certainly not perfect and not instantaneous. So there's a few groups that are laid out here. We've got our innovators, right? Those who are willing to take risks. They often have the highest social status. They have the highest risk tolerance. You don't need to worry about convincing them to do something. They've already done it. There are relatively few of them. You've got your early adopters who have the highest degree of opinion leadership. Among adopter categories, they're the folks who are likely to take an idea and begin to tell you something about how to communicate it and popularize it. You've got your early majority, those who need to see a little proof. You show them something safe, something works, they'll do it, but there's a little bit of watching and waiting. And then the late majority, who are less risk tolerant, often have lower social status in a system, who approach change with a bit of skepticism. They're not going to tell you no. They're certainly not going to tell you yes right off the bat. They're going to wait and see. And then we have this term laggards that he used for those who are the last to adopt an innovation. Laggard in English is not a kind term, so I don't tend to use it, but he used it and I'm citing the model, so here it is. Nobody appreciates being called a laggard. I think of this as the most risk-averse group, those who are least likely to change. So I just want to stress from this, and that we could do a whole session just on this, we see this type of response for a lot of changes and it's normal, right? There are ways to help bring along individuals in different phases of this curve. And not everyone has to be on board immediately. You have not failed if everybody is not on board immediately. It's a good and safe and normal thing for people to adopt at different points in time. The other piece of good news here is that changes at one level in this curve drive changes at the others. And that can help us. If you know where you are, you can use the resources that are available to you to help you so that all of the weight of change is not on your shoulders. Next slide, please. So this is a big slide that I've put together on the life cycle of a QI project, which I usually use to frame series of training sessions. All right. I thought we'd go over this quickly, but in reality, we're going to focus on the first step in this process, as I suppose we should in any process today. When we think about the life cycle of a QI project, we start with scoping that project, and that is about a good problem statement. What problem do you want to address? We then do a needs assessment to understand where that process is unreliable. We plan for success. We get a notion of what we're going to measure. It's important to do that before we have ideas, because that will help us weed out the ideas that are helpful to us from ideas that are less likely to be helpful to us. And then we can do a quick test. We can learn something about where to test quickly to learn the most. There's a discipline and a lot of tools to be helpful with that. We refine that test because we almost always learn something that can help us improve on it. And then we think about spreading it. How does it look in other settings? What needs to change? What factors of it are global? They work everywhere. What factors are contextual? They're specific to a population, to a setting. And then we think about scale, which is different from spread, right? Spread is about how can we adjust for a different setting. Scale is about how can we do more of this, right? If your solution to a problem in a clinic is, well, we just need an extra nurse on staff. Okay. That solution could be spread. It's probably not scalable. You're probably not going to be able to have an extra nurse everywhere all of the time. That doesn't mean that there's not value to that change. It does mean if you're anticipating you can scale it, we want to question that assumption. So as I said, for today, we're going to focus on the first step in this process, but I find this to be a helpful roadmap. And I also want to acknowledge this is not linear. It does not always move in one direction, even though that's the way the arrows point. We take steps back in this process all the time. It is not a byproduct. That's part of learning. And that's an indication that you're learning. So if you find that happening, it's okay. You did not do it wrong. It's just an invitation to have a conversation about what's changed. Next slide, please. So problem statements. Often when I talk with teams for the first time, they expect to come away from their first conversation with me with a goal or an aim statement, and that's not where we start. An aim statement's only helpful if it's aligned with a problem that's commonly felt among the team. And that is not always the case. So if we go straight to a goal or an aim statement and we haven't defined a problem, I am not making the best use of your time. So a good problem statement, one that we can start with, focuses on just one critical problem that is going to have a significant impact if it's fixed. People will feel it. They will feel relief. They will feel a lack of pain. They will feel less anxiety. There are almost always multiple problems that we could address when we start a conversation around change. That's not to say that they all don't deserve to be addressed, but they deserve to be addressed one by one if we're going to affect change that's meaningful. Problem statement offers a concise, a direct, and focused description of an issue that can be addressed with a test of change, right? It is a clear description of your pain point. It describes what's wrong without offering solutions. It's very easy to let solutions creep into a problem statement. And if you don't recognize it initially, you will recognize it later. And often it will be much more time consuming to try and tease out that solution, those assumptions in your problem later than it would have been at the outset. And a good problem statement ought to help you understand what the difference is going to be generally between the current state and the ideal state. So we can move to the next slide. Let's get some practice. We're going to get some practice with a non-clinical example. You're going to help me with my parenting, because when it comes to parenting, I could use all of the help that I can get. So I have a 9-year-old child at home. He has a list of chores that he is supposed to do to help us in the house on a regular basis. One of his chores is to take out the trash when it's full. So Last night, I took the trash out at my home and I noticed that the trash can in front of my house was full. And I know that the day before that was the day for scheduled trash pickup. His job was to take the trash can out to the street last night to make sure it was picked up. And that trash can is full today. So I asked my child if they took the trash out this week. And they responded, yeah. What's my problem statement? What went wrong here? I want to acknowledge there's more than one potential problem in this. There are no right or wrong answers.
I believe a potential problem statement would be failure of trash disposal, to keep it kind of short.
That's the most fundamental one that we can start with, right? The trash did not get taken out. What else? The garbage truck never came? Way to leave that option open. I didn't say that I saw the garbage truck came. They miss weeks all the time. Thank you for calling out an assumption that can bleed into that and have a real impact on our problem statement. My consumption increase, there's a good one, right? Is the problem that we're creating too much waste? Very different from whether or not the trash got taken out. Let's focus on the response that I got. That, yeah. How do we feel about that? Dina, you have a hand raised. Go ahead.
Yeah, so I think that your child is so intimidated by you that he cannot tell you the truth.
Okay.
Yeah.
Okay. My child is so intimidated that he can't tell me the truth. So let's back that up, because that is a perfect instance of attributing some cause in a problem statement. Let's take half of it. Didn't tell me the truth. Right? That is a potential problem statement. He told me something happened that didn't. We can back that up one step further. Was he paying attention when I asked the question to begin with? Both of those point to a communication problem. Now, intimidation could be part of that, right? That could tell us something. We could learn through other interactions whether or not intimidation is contributing to that. And that's a really good hypothesis for what we might want to start with. But one of the things I hope is helpful about this is to recognize there's the basic, if the problem is a child, the father will be the source too. Yeah, that's one of the joys of parenting, right? You never get to dodge that. If the problem's in your kid, you probably have some role in it. Yeah. There are multiple problem statements we can talk about here. Is it about the trash or is it about our communication? And that comes down to my goal. If my goal is just the trash needs to get taken out, okay, I think Mushtaba was right to begin with. If my goal is to have a child who does chores more reliably, maybe the problem that we actually ought to be starting with is one of communication. Because that's a problem that could manifest in another setting too, right? If I expect a room to get clean and it doesn't get clean, that could be attributable to the same problem. So there's no one right answer here. There's a right answer for an individual or a team in a context. It's almost always multiple problem statements. And the more work we can do, and it helps so much to have peers to understand what those different problem statements are, to call one another out on when solutions bleed into our problem statements, because they always do. They always do. It happens to me, and I've been doing this work for decades. It always happens as part of being human. That is really important. We can move on to the next slide, please. So for our example, for the rest of the day, I want to talk about COVID-19 vaccine hesitancy, and we can move straight to the next slide. And I want to ask you for a little bit of feedback in the chat. So in your experience, before we get started on this, what reasons do people give when they refuse vaccination or express hesitancy?
too many reasons. The vaccine causes the vaccine makes us sterile. The vaccine is has been genetically modified. The vaccine has a chip that could track us, even though people are carrying phones that track them on their own, so they don't need to put a chip in a vaccine to track you. So many.
Right? I see somebody said it's not safe. I see the University Hub has an answer in the hall.
Most of the people here in Sudan are afraid of getting vaccinated because they think that vaccine has some major side effects. For example, the vaccines for fibromyelitis in Africa, a lot of people died after getting vaccinated. So a lot of people here think the same thing will happen to them. If they get vaccinated with coronavirus, they will get the virus and they will die eventually.
So side effects, contributions to other illnesses. I see here in the chat, fear and lack of proper knowledge. Their beliefs that vaccines affect their health with time by affecting their genes. They're afraid of side effects. Dina, go ahead, please.
Yeah, so one of the stuff that faced me when I tried to advocate for vaccines was the people do not know the impact of it and the problem that we're trying to solve. So people did not know that COVID-19 is existing. They just heard it on the media. They felt like it's just a drama. There is nothing. So that's why we cannot start on the human nature love to be saved. Everyone wants to be saved. So if they feel or if they felt that there is a problem, a real problem, they will get vaccinated. But if there is no that campaigns of awareness that COVID-19 can kill your loved one and stuff like that, no, you cannot expect them to seek for any solutions.
What a great point. Like, do they believe in the seriousness of the disease to begin with? This comes back to the framework we talked about earlier. If the problem is not commonly felt, we're not going to be helpful in providing solutions. I have heard so many different answers from different groups to this. We've talked about contextual examples like politics or religion or moral or ethical beliefs, trust in the healthcare system and providers. Talk about individual beliefs and knowledge and awareness, and that includes whether or not the disease is a serious risk to begin with. There are logistical barriers to vaccination. How is it administered? Where and when is it administered? Are there costs, including time costs associated with it? What are the attitudes of the healthcare professionals that are providing vaccination? I see a couple more comments in the chat around complications and encounters. And the thought that there's propaganda, malaria kills millions too. We're going to come right back to that. Nice, smooth transition. Thank you, Aman. What I want to say is the reasons that I hear from other groups and the reasons that I've heard for this group do not lend themselves to a single and focused problem statement. And that may be obvious, but it's worth acknowledging the obvious sometimes, right? Vaccine hesitancy is not a problem statement. It's an array of problem statements. It's a collection of problem statements. Just as adoption is not a problem statement, but understanding something about where specifically we are in the adoption process can help us in whittling that down. So we can move on to the next slide, please. Just want to acknowledge that vaccine hesitancy is a spectrum, much like that curve that we saw earlier. So this is the WHO's definition of vaccine hesitancy, which refers to a delay in acceptance or refusal of vaccination despite the availability of vaccination services. They acknowledge it's complex, it's context specific, it varies across time and place of vaccines, and it's influenced by, we could make a laundry list, a long list of factors. And they acknowledge that there's a spectrum here from pure acceptance to pure refusal. This for me looks an awful lot like that adoption curve. If we can move to the next slide, I want to acknowledge that we can layer a little more knowledge on that to make that helpful. So this is the results of some research that's been done in the US around vaccine acceptance personas. And I know that research done in the US is not going to apply evenly to all settings, but I hope that we can take it with the appropriate qualifications and that it can be informative to us. So they did this is an organization called Sergo Ventures that did national surveys of 20,000 plus adults over the past 2 years. And they broke the reasons that they gave for vaccine acceptance down into 5 groups, right? There were the enthusiasts, those who wanted to get the vaccine as soon as possible. You don't have to worry about them. There's the watchful, those who need to see friends and peers having safe experiences. Once they've seen that, they'll get there. There's the cost anxious, those who believe that time and financial cost are the primary barriers, accessibility, availability. There's the system distrusters, pardon me, or the people who believe that they themselves or members of their community have not been treated fairly by the healthcare system, often for really good historical reasons in any country. And then finally, there are the COVID skeptics, those who don't believe in vaccines and hold deeply held beliefs either about this vaccine or this disease or vaccines in general, to be honest. I find this helpful because our heads go straight to the skeptics most often. They're the best stories, right? We talk about microchips, we talk about surveillance, we talk about the fact that, you know, I remember the first time somebody told me that a quarter would stick to my head after I got the shot because I would be magnetized. Turns out a quarter does stick to my head, but it's the oil on my skin. It has nothing to do with that. We go straight to that group, even though we know from everything that we've studied about change adoption, they're way over on the right-hand side of that curve. So unless we were in a place where everybody else had adopted vaccines, that's not where I would advise someone to start with conversations around vaccine hesitancy. I don't want to take anything away from those objections. I just want to say with limited time and resources, that's not the place where I would advise any of you to spend it. I would advise you to focus on the middle. We can move over to the next slide, please. And I want to talk about, because somebody asked me this question on a previous session, and I thought it was really good. Why does any of this matter? Okay, so we broke people down into groups. We put different names on them. Who cares? I love that they asked that question. Why does this matter? What interventions might work best for some of these different populations? So you can chat in some examples if you want. In the name of time, I want to keep us moving though, and just give a couple examples. Let's talk about incentives. We often talk about incentives or rewards for vaccination. So if you're watchful or cost anxious, incentives can be really helpful. If you have a religious or a moral belief that vaccines are not a good decision and somebody offers to pay you, that can have the opposite effect, right? That does not make incentives a good solution or a bad solution. It makes them a good solution for some groups and not for others. Talk about logistical solutions for folks who are cost anxious. Having more clinics in more places at more times may be helpful. For somebody who is watchful, maybe less. For somebody who's a system distruster, maybe not at all. If we focus all of our time on conspiracy theories, we're not going to speak to many of the other groups that are here. So breaking vaccine hesitance down into groups like this, where we have some notion of common objections, allows us to start to hone our problem statement. We'll move to the next slide. I'm going to skip this in the name of time, but I do want to flag that there's a little more about the kinds of solutions that work for each of the groups along the adopter categories here. So I know that the slides will be shared. You have this, and I'm happy to answer any questions in this on follow-up. We can go ahead to the next one. And we can use a sample problem statement for the rest of our time here. Many patients cite misinformation and disinformation as reasons for vaccine hesitance or refusal. We could have picked out a specific population. We want to help the cost anxious. We want to help the system distrusters. In this case, we could also identify sort of a common element across some of those groups. Let's talk about misinformation, which from all the groups I've spoken with around vaccine acceptance is a consistent theme. What can we do to improve the conversations that we have with individuals around mis and disinformation? I want to share a little bit of what we've learned from working with teams about what that looks like. Next slide, please. So I think that starts with prevention, with helping staff or individuals on your team identify misinformation. So what's going to help us pick it out? Is it sensationalized? Is there a lot of emotion to it? Is there a reference to science behind it? Is it confirmed by trusted experts? Does it answer questions that they have? It's important to be open to discussing misinformation without judgment and to practice this. And that is a skill that I think we can practice. Practice is important because sometimes the first time you hear some of these things, it's hard not to laugh or smile. And that's not the reaction that we all want to lead with. I've certainly done it and regretted doing it. Think about how we can create lists of trusted resources to share with staff. So training staff on how to identify misinformation, how to manage their responses to it, I think can be really helpful. Next slide, please. We want to think about awareness, right? How to stay out ahead of the curve, because we know there's so much of this out there. But think about who can help you stay aware of trending misinformation. Maybe this is someone on your team or in your community. Maybe this is someone in your family. I and many other people that I've spoken with have younger family members who are aware of misinformation before I am. They're more active on social media. They're more tapped in. My cousin's daughter can do a much better job of telling me when misinformation is trending than I can myself. So how can I tap into that? How can I learn, right? How can I begin to get a sense that people think you're magnetized after you're vaccinated before a patient comes in and sees me and hears that? If you don't give yourself the opportunity to think through and manage your response to this, you're never going to be in a place to respond ideally. So early awareness, I think, is really important. Think about when and where and how you can have opportunities to learn from them. Maybe it's checking in every week or every month, and what you will need to do to make that happen, right? How you can make sure those interactions happen. Is it clearing time on your calendar? Is it making sure that you have time to meet someone for coffee or for tea or for a meal? Whatever it is to make sure you can stay out ahead of that wave. Next slide, please. I want to think about how you decide what to raise, because there's too much misinformation out there for you to respond to, right? So a few questions that can help you think about which of these pieces of misinformation deserve your time and attention. What are you seeing shared most frequently? What are you hearing at work more frequently, right? The first time that I heard I was going to be magnetized, I thought it was silly. And then I heard it again and I thought, oh, wait a minute. Have you heard new concerns you don't know how to respond to? That's a good sign that it deserves your attention. Have staff come to you with specific questions? Are other people bringing these to you? I want to acknowledge when you're doing this, this is about information, not individuals, particularly if you're working in a team. If people are bringing you questions, I would not encourage you to ask them to attribute those questions to members of the staff. I think it's more important to know the questions out there than who it's coming from. I think it positions you better to address it, and it also puts the person who brought that information to you in a safer space where they can maintain their relationships with other members of the team. Next slide, please. Then I want to think about preparing your responses. So once you've identified something that's important, right? A piece of misinformation that you think deserves some preparation. Ask yourself a few questions. What are the issues that would drive someone to believe that, right? I may think it's silly that somebody believes that they would be sterilized by this vaccine, but I don't think it's silly that somebody's concerned for their family. That's much easier for me to empathize with. So whatever the objection is, find a way to get to those beliefs where you can think, that I understand. You have a concern for your family. Let's not focus on how it's coming out. I can empathize with that. I can have a better conversation with you when I'm thinking about my family and I'm thinking about the way you feel for yours. What questions could you ask to learn more? We'll talk a little bit more about this in just a sec. How can you acknowledge the importance of the issues and not the information? So I can tell somebody, I hear that you have a concern for your family, and I understand that. I have a family too, and I struggled with this decision. That doesn't say I understand why you think you'd be sterile. It's different, but acknowledge the importance of the issues and not the information. Think about what other sources of information you could recommend. Have an alternative ready. If they ask, you're going to want to have an answer. And then what do you know medically and what are your sources? So I'm not a clinician. I don't offer medical advice. Occasionally somebody calls me Dr. Wetherhold. I don't correct them, but I certainly have clinicians that I can refer people to when they have medical questions. So if you are a clinician, understand what you know or what you might refer out. If you're not, who do you have that can help you in addressing that? Next slide, please. And one of the things that I find really helpful for this is a technique called motivational interviewing. Now, this may be something that some of you are aware of already. Motivational interviewing is a person-centered conversation to address a common problem of ambivalence to change. Ambivalence is just mixed feelings. Part of us wants to change and part of us doesn't. It's collaborative and it's goal-oriented. It helps us tune into the language of change. And it focuses on strengthening personal motivation for and commitment to goals in a way that's grounded in acceptance and compassion. Motivational interviewing tells us people do not change by rejecting their beliefs. That is not the way that change happens. They change in ways that they see as consistent with their beliefs. These techniques could be used in all problems in my life, in my opinion. I could not agree more, and that is part of what led me at some point to learn more about motivational interviewing. This is a great skill set to learn more about if you don't already for any number of problems that you could encounter. So people change in ways they see as consistent with their beliefs. We foster change by strengthening a person's own motivation and commitment to change, by understanding what's important. If their concern was out of a desire to protect their family, their acceptance of the vaccine will likely be out of a desire to protect their family. And there are ways to have that conversation. So motivational interviewing trains our ears to listen differently for why people might make a change. And I heard somebody say once, this was a clinician that I was speaking with, I thought if people understood their problem, they would change, and that wasn't the case. He said there was no correlation. It didn't matter that they understood their problem. And that was what led him to motivational interviewing. Next slide, please. The spirit of motivational interviewing, the attitude that we pursue this with, is one of compassion. We want to care about what's important to that person and try and see past the objections to what those issues are that are driving them to embrace them. It's one of acceptance, right? That doesn't mean that we need to validate what they're hearing, but accepting that they have a right to change or not to change. I think one of the assumptions that motivational interviewing can help us recognize and embrace is that now is the right time to change. We know from that adoption curve, now is not the right time to change for most people. How can we help you identify those for whom it is most likely to be the time to change? Partnership, working with another person and recognizing them as an equal, and bringing out their ideas and strengths and knowledge. What do they know? What knowledge do they have? Motivational interviewing, a lot of people recognize it as a technique that is used in addiction treatment. And part of what is really important in that context is recognizing however we feel about addiction, living with addiction is hard, and it requires expertise. It requires skills and knowledge to live with addiction for a long time. The sooner we can recognize and begin to draw on those, the more likely we are to change somebody's beliefs or attitudes about their own addiction or their habits. Next slide, please. I know that we're moving a little quicker here. This is the statement that sunk me when it came to motivational interviewing. This is the statement where I thought, okay, I get it now. Because in healthcare, we are taught not to use the word non-compliant. Right? It's an easy way to think about patients. It's a dismissive way to think about patients. We are taught not to use it. And when the first day that somebody told me, well, we're all non-compliant, I felt like something had split wide open for me. It seems obvious. Maybe it should have been obvious to me, and that says more about me. We are all non-compliant and ambivalent about change. We all have mixed feelings about change. What motivational interviewing can help us do is to normalize that and to create an environment where people understand you're non-compliant too. right? I don't floss my teeth every day. I don't drive the speed limit all the time. There are dozens of ways in which I am non-compliant. There are dozens of ways in which each of you are non-compliant and have mixed feelings about change. And that's okay. If we can draw on that and have that realization, I think it can be a really helpful one. It helps us send a couple of messages to patients. One is that being treated well by me is not contingent on you doing what I want. I'm here to help you. You don't need to do what I'm expecting for me to treat you well. In other words, it's normal to have contradictory feelings. It's normal to not be sure what to do about change. So motivational interviewing is a really helpful method for communicating and exploring non-compliance and ambivalence. And I think it's a helpful technique to bring to this conversation as well. Next slide, please. Couple more frameworks that I find helpful. This is something called the OARS framework. It's an acronym: open-ended questions, affirming statements, reflective statements, and summarizing statements. When I was trained in motivational interviewing, I found this helpful because this is actually supposed to be a pretty even distribution. I want you to notice 75% of what's up there are statements. So when I was trained in MI, they sat me down with somebody who was a patient, and they said, you have 8 minutes to talk with this person. You can ask 3 questions. I thought I was done for. I ask questions for a living. Telling me to talk to somebody for 8 minutes and ask 3 questions was excruciating. I don't want to pretend that's the way it has to work all the time, but it was so helpful because relying on statements made me listen differently. And I think it can make you listen differently too, right? So I've included some examples here of how we can use those, right? Affirming statements. I can tell you've put a lot of time into learning more about vaccines. Reflective statements. How can you reflect that you've heard something back to them and not just, you told me this? You're clearly concerned about the impact that vaccination will have on your health. Summarizing statements where you can bring multiple things together. You've mentioned a few concerned about your family's health. You mentioned your spouse, you mentioned your child, you've mentioned your parents. These kinds of things get people to talk and get people to talk themselves into change often. So questions are valuable. I think it's helpful to use a framework like this to not rely entirely on questions and to start to use more statements in your interactions with patients or with anybody. You know, to the point in the chat earlier, this could be used in a lot of different problems in your life. Next slide, please. And the last didactic slide I've got for today is just a quick framework for how to think about that. And don't let the 2 asks and 1 tell fool you. I think most of the work happens in the middle here. But to understand how to frame interactions with patients in this ask, tell, ask, which is adapted from motivational interviewing. It's a nice, easy framework for thinking about how to frame conversations with patients, right? We could start out by asking permission to give information. Is it okay if we talk about vaccines today? Then we can listen, use some reflective statements. We can share information. So I heard you say this is on your mind right now. Is that fair? I heard you say this and this. Can I share this with you? At the end of that conversation, think about how you can wrap up with a question. How do you think we should proceed? What do you think our next step should be? We can move to the next slide. It's sort of a similar version of this with different prompts. You could start with, what information would you like to know? Or you already know a lot about this, but are there any more questions you have? About how to present a couple of options, and then maybe use teach back as a technique at the end, right? I'd like to make sure I did a good job explaining this to you. I have to have this conversation with a lot of people. Can you let me know what you heard? Or can I tell you what I heard? Right? That's a way to frame something back and clarify that I think can be really helpful. So we've got a few examples in here, but I want to check in. Mustafa, how are we doing on time?
I believe we still don't have enough time, but you could go through the examples, won't be a problem.
Okay, how long would you like me to take before we transition to the case study?
15 minutes if that's possible.
Okay. That we can do. So those are just a couple examples of how we can use this framework. And the next few slides are some examples that we can work through ourselves. So let's move to the first one. We're going to present a few, what I hope are familiar examples.
Yeah, I apologize, Mr. Wetherhold. I may have made a small mistake. If it could be a little shorter, like say 5 minutes, that would be a little better. Yeah, sorry.
No problem. We'll do one, maybe two. We'll see how responses go. I know that we got started a little late. So a common objection that we hear, I've already had COVID, so I'm already immune. What would you start by asking this person? How could you open this conversation with a question? That's an interesting thought. How do you know you're immune? Yeah. Why do you think that? Don't be afraid of short questions. Short questions are great. Any interviewer will tell you short questions get people to talk. Fatima, go ahead, please.
Would it be okay to share a little bit of information on how COVID works?
Can I share something with you about what I know on COVID, right? A little information on how COVID works. That's great, because you're starting to tuck into what some of the issues are that are underneath of this belief, right? They're clearly telling you there's some space to learn something about the disease. So you're asking if it's okay for you to enter that space. What might we tell them? What facts might be helpful to this person?
Okay, I can tell them that this is will go to improve your existing immunity. Simply, I can tell them that this vaccine is going to improve your existence immunity. It doesn't harm you.
I love that, because you're not just saying, no, you're wrong, you're not immune. You're saying, you're right, you do have some immunity. How can we improve that? How can we sustain that? Right? You're taking something that they believe and you're actively building on that. You're creating room for their expertise, however you may feel about it. I think that's wonderful. Thank you. I see a comment in the chat. This is great from you. What kind of vaccine did you have? That's good information to get. Yeah. And how might we wrap up an interaction like this? What kind of question would you ask at the end? See another chat in here. COVID is evolving and there's more than one variant. So there's a great fact to share, right? That may have been true at one time, but this disease has evolved a lot. Have you thought about how that impacts your immunity? So we could end with, what's a good next step? How are you feeling about vaccination? How are you feeling about your immunity or your susceptibility to this disease? Do you have other questions? Would it be helpful for us to talk further in a week, a month? Right. Of the information that you've heard today, what do you plan to use and how, right? Have you learned anything from this conversation? You might want to start that with, here's what I've learned from this conversation. Have you learned anything that was helpful to you? Make them tell you no. Most of the time they won't. Sometimes they will. We don't need to have a thick skin for that, right? Great example. So I know in the name of time, we should move on. We've got two examples on the next slide in case you want more cases to work through, either for yourself or others. I love this one. I saw an Instagram post that shows a woman who became unconscious after getting a COVID vaccine. That's a good one to run through with a group. Or the last one, we can move forward. What are we including here? I've got a bank of like 10 of these. Putting a foreign substance in my body just doesn't seem natural, right? These kinds of prompts can be really helpful with working through teams. We can move on to the next slide, please. And that is it. I really, again, appreciate the opportunity to be here with all of you. I will stay on for the rest of the session. If you have questions, you're welcome to ask or contribute those to the chat. If you would like to stay in touch or ask any follow-up questions, my contact information is down here. But I really appreciate being here today, and I'm grateful to all of you for the time that you've spent in this session. I hope that you've taken something from this that can be helpful to you in your work. Thank you.
I believe we definitely have, and thank you so much, Mr. Wetherhold. As I said earlier, the techniques and everything that you taught us there are things that we could use in general life, not just in the medical field or vaccine hesitancy. These are, in my opinion, ways that we can look at any problem that we face and find a more structured and better understanding approach towards solving it. So thank you so much. And as we said earlier, the slides are going to be available on the iEcho platform. So if anyone wants to go through these examples that we had to skip in the interest of time, you can find them there, and feel free to practice them with your friends or practice them with a family member or anyone you wish to. And as Mr. Wetherhold said, if you have any questions or comments, you can feel free to leave them in the chat. And yeah, you can feel free to leave them in the chat, or you can raise up your hand and we can get to them immediately. But as we said, in the interest of time, we're going to be moving on to our case-based discussion today. So, oh yeah, sorry. Before the case-based discussion, just a few seconds, I'm going to talk to you about the feedback. As you know, we sent out a feedback link form that we've been sending one out during the last 2 sessions. It was a Google form, and now we finally got the actual feedback form uploaded onto the iEcho platform. So you can just log onto the platform and go to the session, or after the session ends, you're going to find a button that says submit feedback. So we invite you to submit your feedback about our sessions. It helps us understand how beneficial they are and how we can move forward and make them better for all of you. And thank you so much. All right, so as I was saying, back to our case-based discussion. Mohab, can you hear me?
Yes, I can hear you. Can you guys hear me well?
Yes, very well. Okay, take it away.
Okay, perfect. So, good afternoon, everybody. My name is Mohab Abdel Hamid. I'm a student in University of Jazeera, Faculty of Medicine. I'm in my 4th year. Today's case is set in a hospital, in a teaching hospital that provides vaccines and is frequented by medical students from 3 different medical schools. It reports a much lower rate of vaccine uptake in regards to childhood and adult vaccination compared to other hospitals in the area. When asked why some patients cited vaccinations compared to other hospitals in this area, patients cited distrust in the medical students working there. While others spoke about they heard the hospital get expired vaccines due to funding problems, and others said vaccines are not needed at all. You decide to implement a quality improvement project to resolve this issue, being one of the students there. Our key questions for today. Can we name some of the first steps that we'll take towards formulating the plan?
All right, so floor is open for everyone. The first question was to name some of the first steps that you're going to take towards formulating your plan towards making this QI project solve this problem. So please raise your hand or write your answers in the chat, and Mohab will get to them immediately.
Yes, you guys want to participate?
Sorry. And if I may add my input to this, I believe that one of the first steps that we're going to need to take is understand the problem from the patient's side, because in the problem statement and description of the case, we have the perspective of the physicians who are working in the hospital that our vaccination uptake rate is low, and these are the reasons that the patient cited. So we need to understand this more from their side. We need to ask them more questions and understand why they even believe these things, where they heard these things from, so that we can work on that too as part of our project moving forward.
Yes, this is a great thing, yeah, Mustafa, because like understanding the main problem is the key to finding solutions. Because if you can identify the problem, we can work on towards making the solution. So what do you guys think the problem is here?
And as Mr. Wetherhold said in the chat, how many problem statements can you find in this case? Sorry for interrupting. Please go ahead.
Thank you. Sorry. I think people always like to cite bad stories and bad examples to justify their refusal of being vaccinated. But from our part, as a caretaker of these people, we have to engage the media before starting this vaccination program, to engage the media to counsel these people that these personnel who are working on the vaccine program are well trained, and you have not to worry about their training. Thank you.
Yes, I 100% agree with that. Working through the media will help us spread more information. It will always also help us assure the population that the people working in the hospital are qualified and are people you can trust. That's a very good answer. Okay, and as we said, if anyone, we have an answer in the chat, Mohab.
Fatima said that, Iman said that yes, promotion and keep updated. That's yes, exactly, because like this is one of the most important things to consider, because seeing things in the media can be a great help to make people who are hesitant in getting vaccinated and normalizing getting vaccinated, because it feels normal to watch it in the media, then they'll do it. Fatima also said we need to decide on which problem. Yes, there are 3 problems. Okay, what do you think the problem says, Fatima?
I think we have 3 problems here. One of them is the distress in medical students that are working there. The second would be the rumors they are hearing about expired vaccines and funding problems in the hospital. And the third one would be vaccines that are not needed at all. So I think we need to identify if these problems are on group or on individual levels first, and see if we can actually apply quality improvement to that. Which ones we can apply quality improvement to, and which ones we should just, bring these people to the corner and talk to them and fix them on an individual level.
We have another problem in the chat. Make it easier to access the vaccines, like taking units at level of health centers. Yes, this might be a great solution to the financial problem and the logistic difficulties in this problem. Mr. Jeffrey, would you like to give us some of your inputs?
Oh, sure. This is a great case. Thank you for putting this together. So we've got at least 3 problem statements there. How would you choose which one you start with? What would your metrics be for choosing, or maybe what information would you want to know that you don't have?
I think we should listen from the patients first to see what's their main concerns. I think distributing surveys around the hospital to actually get to know the measurements and the real data of the problem, and then we can decide which problem can be faced. Of course, like some problems might be easier to fix, but others, like the ones saying that the vaccines are not needed, can be disregarded at this moment, to focus on those who actually want the vaccine, but just are hesitant to believe that the vaccines are working. We have another answer in the chat. We need to involve the key persons in the community because they will have a prominent impact. Yes, I think this also might help because listening to people from their own level would actually make it more relatable to people to listen to them, other than listening from a doctor or a medical professional. Okay, I think that's it. We can move on to the next. Farah, do you want to participate?
Yeah, you have a hand up in the hall.
Okay.
Okay, first of all, we should make sure that those patients are informed that the interns or the students working in these hospitals are working under supervision of other registrars and specialists. So everything that students say to them is scientifically and correct. So we need to make the patients trust those medical students first, because everything they say to them will be correct and fix the problem.
Yes, that's a good place to start, actually. Okay, we can move on to the next question to save time. Using the ask, tell, ask framework, the one that was previously mentioned, how will you approach the system distrusters and the cost anxious groups? What do you guys think? You can write in the chat or you can participate.
Yeah, for the system distrusters, well, I'm gonna ask. I'm gonna give my opinion on both. For the system distrusters, we can start by asking them something along the lines of, well, why do you think the medical system is not to be trusted, or why do you not trust the doctors in the hospital? If they say that, for example, it is the amount of students working there, and how can you trust students working in the hospital? They're just learning. Then our tell would be something along the lines of, well, you know that the training that these students are receiving is from top-notch doctors working at the hospital, and they are also supervised to make sure that the level of care that the patients receive is not compromised on any level. And our final ask would maybe be something along the lines of, so now that I've told you about this, has your perspective on the students working in the hospital changed? And also maybe a side joke we could make is, wouldn't you want your son or daughter to be a student working in this hospital one day? What do you think about that?
Okay, that's a great way. Does anybody else have an answer? You can open your mics or you can write in the chat. Okay, here we have an answer. Fatima said, I think we can kill two birds with one stone by carrying out mobile vaccine clinics. Yes, that's actually a very good idea because it brings the vaccines to the people themselves without actually having to go to the hospital and without actually thinking about the problems that the hospital is facing, whether it's funding problems, whether it's medical students working there. So mobile vaccine clinics can kill two birds with one stone. Yes. Okay, we have an answer in the chat.
I believe you can move on to the next question.
Okay, sure. Do you think that practitioners are part of the reason of the low uptake? And if yes, what will your intervention towards them be? Okay, do you guys think that the doctors involved are actually a part of the problem or not? If yes, why?
Okay, practitioners are the gate for achieving successful vaccination program. In order to achieve successful program, we have to engage them What's required from them is that to tell all the patients whom they see about the importance of the vaccine, ask their patient if they are vaccinated, and if not, why, and to justify to them that it is important to take the vaccine and it is safe, and benefits outweigh all the risk from taking it.
Yes, Dr. Kamal, for the doctors to practice good communication with the patients would actually help more to relieve the problems that the patients have and to actually understand what they think, to actually be in their shoes as the person. So that's actually really helpful. Fatima said, we don't always know how to deal with vaccine hesitancy and the best way to approach it. Yes. Can you elaborate, Fatma?
Yes, elaborating would be just like the thing we learned today, that Mr. Jeffrey shared earlier about trying to actually analyze whatever the statement we hear from the patient is and try to understand it to a deeper level that we can relate to. That was a skill I never thought of before, and this is something I've learned today. So I think that now that I know this, I will definitely be using it when I approach patients with vaccine hesitancy.
Okay, perfect. Dr. Iman said, unfortunately, she encounters with patients who are advised by specialists not to take vaccines. This is actually the problem with healthcare professionals, because the rumors in Sudan here are quite strong and they're quite impactful, regardless of the knowledge you have. So I think dealing with this first will actually help the problem, will actually ease helping the problem with the community. Like if we address the problem with the practitioners first, it will ease the addressing the problem to the rest of the community.
And if I may add something, I believe that this is a very good look or a very good piece of insight, because sometimes we tend to ignore the fact that practitioners and specialists working are also humans, and they're also susceptible to all these pieces of misinformation that they could see. They could also be part of the people who believe that COVID-19 vaccines cause infertility, for example. So then not just they would be the people affected by this, but they would also affect their patients. So we need to target our approach toward the physicians as well as the patients and everyone in the community too.
Yes, that's quite correct. Okay, does anybody has something else to add?
Before we do wrap up the case presentation, I would like to invite Mr. Jeffrey Wetherhold to give us some more insight on this, especially this last question about practitioners, if that's possible.
Happy to, I appreciate it. So any of the three problem statements that are clear in this case are worth time and investigation. And I think the questions that I would ask could be very different across the three of those. You know, as an example, some patients cite distrust in medical students. I want to know, what drives that mistrust? What have your interactions with medical students been like? Sidebar on that, have they actually had any, or are they just acting on information, right? What has your experience been with the healthcare system in the past? Like there are lots of questions that we can use to open that up. The issue around misinformation or engagement with practitioners is a tough one. We could do a whole call on just dealing with misinformation from providers, to be honest. Actually, we're planning one of those for a different echo. So I think engaging practitioners, you know, Mustafa made a really good point, to treat them like the human beings that they are, and to think about how we can use the same tools that we would use in conversations with patients, with practitioners. My interest in motivational interviewing as a technique is driven by using it with clinicians and practitioners. That is not a commonly held sort of belief. Most of the training that I've been in around motivational interviewing has been with people who are applying that to patients and not to clinicians. But I'm a big believer that our providers and clinicians are people too, and they're imperfect and they deserve empathy as much as our patients do. So I really could not agree more with the point that we can take some of the things that we traditionally think of as being patient-facing and make those provider-facing as well. And then be really clear in the questions that we ask with patients. What are you hearing from providers? What other conversations are you having? I don't know if we always do that, right? So have you talked with any other providers about medical students? If you talked with any other providers about currency or expiration of vaccines, what have they shared with you? Where do you get your information on side effects or whether or not vaccines are current? Right? There are some more general ways to get at that, but I think I always start with questions, but I would start with questions and probe with patients on any of these issues for where there may be a practitioner role, and then be courageous about using some of these tools in conversations with practitioners as well, and just treating them like the flawed and non-compliant and imperfect individuals that they are, and to acknowledge that they also have they in some way, shape, or form as practitioners, I'm always going to start with the assumption that they have the best interests of their patients at heart. In the same way that I would start with somebody approaching me with misinformation, is there are issues under that I can share, right? With a practitioner, I don't believe you don't care about your patients until you've proved otherwise. So knowing that motivation exists, how can we tap into that?
Thank you so much, Mr. Wetherhold, and that is some really great insight. Talking to them and knowing that their motivation is towards making their patients' lives better is something that we could really use in talking to them, and also convincing them towards the uses of the vaccine in itself. Because another thing that I believe would be useful is that because physicians are usually more inclined to look at data and research in a more effective way, we could also talk to them about that. And because showing a research paper to a patient would not be very useful, they would just tell you that they might say that you're trying to cheat us with this paper, because I don't know who looked at it, I don't know who created it, but physicians understand that more. So yeah, I believe that it is very useful, and thank you so much. Mohab, do you have any final words for the case?
Okay, thank you so much, Dr. Jeffrey. Thank you so much to everyone who attended. Thank you so much for participating, for the lovely insight. I think we should wrap it up, and glad to be here.
Yeah, thank you. Thank you so much, Mohab, for coming to us with this case and presenting it. And before we end this, we also have a final comment from Samah Abdullah in the chat saying, it's easier to provide information to a person for the first time than correct misinformation of a convinced one, if you understand. Yes, that is 100% true, because forming that first impression and giving that first piece of information, people tend to stick with it more than information that they're hearing on top of other information. So thank you so much for that insight. All right, and for the interest of time, I don't believe we're going to have any place for our general discussion, but I'd like to thank you all for a very great session. I'd like to thank Mr. Wetherhold for this amazing and beautiful session, and I personally got hypnotized during them. I've said that I've been to 2 of his sessions before, and I'd go to 5 more and 10 more if it's possible. So thank you so much, Mr. Wetherhold. And yeah, thank you, and see you next time. If you have any queries regarding the program, or have any questions or any comments, please don't hesitate to contact us, the program providers, myself, Fatima, and Ahmed at these emails. Our next session is going to be on the 5th of November. It's going to be an intro or introduction to public health with Dr. Fawatih Abu. She is a community health epidemiologist at the University of Connecticut. She is also a graduate of the University of Jazeera Faculty of Medicine, so she is one of our own. And as I said earlier, you could find this presentation on the iEcho platform. Also, please go to the session details and fill out our feedback form. It's only going to take about 2 minutes, I believe. There's about 10 to 11 questions, I think. And thank you so much. Ahmed, Fatma, do you have any last comments?
No, that'd be all. Thank you so much.
No, thank you so much.
All right. Thank you again, Mr. Wetherhold.